Welcome, everyone. Welcome to another episode of Ben's Den. And I'm very excited for my guest today. He's my first guest of 2026, Mike from MEDITECH, someone I've had the pleasure of knowing over the last few months through our joint work on TEFCA. And he is a senior director and the head of interoperability for MEDITECH. And we all know who MEDITECH is. But I'll let Mike introduce himself to you all, and we'll get started from there. Mike.
Thanks for having me. Like you said, my name is Mike Cordeiro. I'm Senior Director over Interoperability, Product Market Strategy at MEDITECH. I feel like I've been working in the interop space for the majority of my career. So thanks for having me.
Thanks, Mike. And you've been with MEDITECH pretty much your entire adult life.
I grew up at MEDITECH. It's kind of a staple there, right? So you start off entry level and you kind of work your way through the ranks. And that's kind of been my journey.
It's amazing. And first, before we kick this off, Mike, I do want to share my condolences to the entire MEDITECH family. Did read the news about Neil passing on, and when a founder kind of exits and leaves, or it's kind of leaves its impact regardless of the duration of our life. Yeah. So I'm sure he left a
amazing legacy. Yeah. And he left his impact throughout the entirety of this industry. And I think, everyone knew who he was and what his contributions were. So, I think we're at a point right now where we're just kind of celebrating his successes in his life and his legacy.
That's amazing. That's amazing, Mike. So let's dig in. Yeah. Something that we both are extremely passionate about, something that got us to know each other, and we participated on many initiatives together. But let's talk about what true interoperability really means, Mike, right? Yeah. I mean, for the longest time, you were saying, okay, hey, data movement at some level is interoperability. If I can get data to go from point A to point B, mission accomplished, right? But I think what we've learned in the last 5 years, especially post-pandemic, is that you have a bigger challenge than just moving data from one place to another, right? Yeah. What do you do with that data when it arrives at point B, and how do you apply it? How do you contextualize it? How do you normalize it? And how do you put it to action, right? Yeah. So where do you think we are?
I think that's really well said on your part. I mean, because if you were to ask me that exact question like 5 years ago, my definition would be exactly that, kind of very technical. It means sharing data between point A and point B, right? Because we're at that point, we were just kind of building the plumbing, right, to make this data flow. But I think today in time, interoperability means something completely different. I would almost say it's a lot more sophisticated in that, there's this concept of contextual data intelligence delivered at the point of decision, right? So if you look at that contextual, right, what does that really mean? It means it, makes sense in workflow, where it's being used, right? So it's no longer just dumping a 200-page CCD in someone's inbox and saying good luck, right? The intelligence means we move beyond the raw data to kind of like what's actionable. So it's not just asking, can we get the data anymore? It's asking, what should we do with the data once we have it? And then, at the point of decision, that means it arrives exactly when and where the clinician needs it to make the best decision for the patient. So I think, true interoperability now has multiple dimensions, maybe. And the first is that technical layer. Can the system actually talk to each other? But then that semantic layer, do we share a common understanding of what that data really means? But I think the last one is probably most difficult, is kind of that operational layer. Can we actually use this data in daily workflows without actually creating more burden and actually hindering, the benefit? So I think the bar for true interoperability is, it's not did the data move, but did the data matter?
Right. And in your experience, Mike, obviously we have a perspective on the challenges that we face when it comes to realizing the ideal version of interoperability, right? But in your experience, it obviously is not a technical issue. You and I know that very well, right? Yeah. We know operationally there is a gap between, data and clinical, right? Clinical ops.
Yeah.
What do you think of it from a cultural standpoint? Like if an organization or a network that participates in interoperable, initiative, are they culturally aligned to adopting a data-first approach to drive better outcomes? Do you see challenges there from your perspective?
Yeah. So I think I think there's like two aspects there, right? So there's kind of this operational gap, and then there's kind of this cultural gap, right? So, from the operational gap, those are a little bit trickier. And that's where you see organizations maybe struggle a little bit in the day-to-day. And the biggest one is workflow integration. So we've got really good at making interoperable data available, but we need to make it useful in the workflow for the clinical workflow, right? So a physician is in an exam room with a patient and they get an alert that records are available from one hospital, great. But if that means that they have to stop, access an inbox or download a PDF to actually review that information, then, that's a disruption in workflow. So, there's also concepts of alert fatigue, too much data, right? So honestly, you need to actually look at operationalizing how this data can make an impact and it not be disruptive. And I think when that's done within workflow, and we do that here with MEDITECH within our EHR, right? We have tools like Traverse Exchange, which is our network. It brings data within workflow. It uses AI to make sense and operationalize it, but you need to make the data useful. And if it's burdensome, then operationally, it's just not going to be widely accepted, right? And then like culturally, I think some of the biggest challenges culturally is the fact that, there's this syndrome where folks feel like, hey, I'm not going to really rely on this data because it wasn't authored within the organization, right? So you're kind of looking at external data, but not maybe entirely trusting it. And I think that we need to get to a point where, we view data as a competitive asset, not just as a competitive asset, but like a patient asset, right? And that the incentives are aligned properly. If you look, and this is probably within your wheelhouse, right? So there's this fee for service model. Does it reward data sharing? Probably not, right?
Yeah. No.
But, there should be incentives around better outcomes relative to decisions made, and those decisions are impacted by data. So, I think that we need to make sure operationally it makes sense to use that data within workflow. And I think culturally we need to progress to a point where we're trusting data from these external organizations as much as the data we have internally, right? Because there are standards around provenance, where it came from. And, we just talked about contextualizing and making sense of data. So I think there needs to be more trust in data. We need to kind of move beyond that syndrome of if it wasn't authored here.
And one of the things that we saw, especially with the work that we've done, Mike, is that sometimes the trigger for that cultural transformation happens outside in. What I mean by that is, if you are participating in let's say a payer contract or some kind of a community program, right?
Yeah.
Where your success in that initiative is dependent on you rationalizing with what's happening outside of your own walls, right?
Yeah.
And the only way to do it is a data-first interoperability based approach, right? So if you take value-based care, for example, every organization that is participating in a VBC contract today cannot afford to be non-interoperable, cannot afford to be non-data first, right? So it becomes a matter of survival. It becomes a matter of existence at that point, right? So that's something that I have personally seen change the, cultural attributes of these organizations that are adapting to value-based care. Obviously, it becomes harder when the organization is larger, but mid-size, multi-specialty groups, primary care groups have done well when it comes to adapting to these opportunities,
Yeah, and I think it's like you said, it's a cultural change, right? It's embracing data exchange. It's embracing interoperability frameworks. It's leveraging trust elements of those frameworks to understand that you're going to get that data and you need that data to make those informed decisions, not just for the patient, right? But organizationally, to your point, how are you managing, large populations of patients, right? How are you realizing value? And so, yeah.
Awesome. So moving on from there and kind of understanding that, okay, it's interoperable when it's truly applied, right? So now let's look at that edge, at that endpoint. How do you see AI and interoperability coming together, right, as a true enabler of patient-centered care? So we know like they both kind of like need each other, right? Interoperability is something that we've been talking about, working on for decades. And then you have AI, something that's becoming a horizontal force to reckon with in healthcare, right?
Yeah.
And I know MEDITECH has already, ventured into the space. You have some partnerships on AI. I'm sure you're building your own AI and whatnot. But talk to us a little bit about, from your posture, from your point of view, how do you see this, Mike?
Yeah, so I think AI is fundamentally transforming interoperability from a data plumbing problem into an intelligence delivery system, right? So right now, clinicians are drowning in data. A single patient might have records scattered across 5, 7 plus more, healthcare organizations. So we've got really good at pulling all that data together, right? That's the interoperability piece. But we have to create, or we'll create this new problem, right? Which is too much data, right? So now physicians, they might have a 40-page plus external document sitting in their queue. They've got 15 minutes to see the patient. That's probably not helpful, right? But if you're using AI, that becomes transformative, right? So instead of dumping 40 pages of documentation onto a clinician, AI can say, hey, here are the 3 critical findings you need to know from these 40 pages, right? And it's intelligence, it's not just data. So it goes beyond just data curation. AI can provide predictive insights, and it can analyze patterns across many data sources. So I think that's kind of the transformative element, around AI, where you can buy multiple discharge summaries that shows that the patient's been in the emergency room 3 times in the last year. Combine that with their lab results and some social determinants, and you can kind of synthesize the fact that, hey, this patient is extremely high risk for a hospital readmission. So AI is helping make sense of all of this data, right? And we have these frameworks, we have TEFCA, we have CMS-aligned networks, we have all this plumbing, all this data is flowing in, but now we're actually using the AI to apply intelligence and drive insights behind that data in real time.
And I think there's this lot of focus on what's possible, what's capable, and all that, right? But there's 2 things I've been thinking about, Mike. One, we've always had this issue in healthcare where, with technology especially, there is this utopian vision for what technology can do in healthcare. And then there's the realities of a Tuesday afternoon at a facility, dealing with patient flow, real, clinical workflows and whatnot. And I was looking at this chart, which I thought was mind blowing, which was this research that was done on adoption of ambient AI technology. And there's this mind blowing stat where when the technology is launched, in the first 24 hours, you have 88% of clinicians trying it out, which is great, right? So nobody's resisting it. Everybody's giving it a shot. Everybody's getting on it. But more than 50% of that 88% cohort drops out of using the technology within 72 hours. Now, you can call it data bloat, call it workflow friction, call it whatever, right? So from a MEDITECH standpoint, what are you seeing at the point of care? Are you seeing AI deliver in the work that you guys have done, or is it still premature to kind of conclude?
No, it's definitely delivering. So, our approach to AI, we kind of have this mantra internally, like thoughtful, deliberate approach to enabling AI within the workflow within our Expand CHR specifically, right? And so we've noticed that those generative workflows that you're describing, right? So it could be using AI to generate summaries like hospital course or nurse shift handoff, right? Those particular workflows are definitely having a time savings impact as it relates to the amount of time a nurse might take to get up to speed on a patient, or the amount of time it might take to discharge a patient. We're actually seeing real ROI against that. Relative to some of the ambient workflows around, using an AI scribe, at the point of care, so that clinician's spending more face time with that patient, that clinician is seeing some time savings around, authoring their note. That's real, but I think that there is more to it than just, reducing the cognitive load on the patient, on the provider. It's also about kind of these secondary benefits to ambient relative to the quality of the note. And I think the quality of the note might directly correspond to, more optimized reimbursements. I think we'll start seeing a lot of ROI against that. But to your point, relative to the technology, and I think this is true of any technology, if it doesn't resonate, if it doesn't hit initially with a clinician, they stop using it, right? If they see immediate benefit, reduction of cognitive load, or real other ROIs against it, then they're going to use it. And I think for us, we see that with our kind of deliberate approach to AI. We want to make sure that these workflows are tight. We want to make sure that there's actual ROI against this technology. We started delivering interoperability tools like Traverse Exchange, for instance, our network, right? It wasn't just about creating the plumbing to exchange data. It was about, how do I deliver these 40-page CCDs in a way that's going to make sense for the clinician? And we were very deliberate when we released these workflows to ensure that it resonated, right? Because we had that one shot at clinician attention relative to utilizing the technology. So I think that stat is very true, what you're pointing out, that people start using it and then it drops off. I think it drops off because they might not have seen immediate value, right? So, and that's one thing that we're careful about at MEDITECH, and we're careful about the way in which we approach technology or complementary technology to our EHR, like AI, is we want to make sure that the workflows are sound, there's a real ROI there, and folks can see the benefit.
Right. And that's one of our core philosophies when it comes to adopting AI for our own platform as well, Mike, is that we are looking at enabling AI or applying AI to mature pre-existing workflows, right? So you're not trying to change the dynamics around care coordination, for example, right? We are looking at, okay, this is the existing workflow. How can you amplify and augment it using an agentic approach, and that I think will lead to more effective adoption. And then it also set the stage for a more radical approach to adopting and enabling AI. So we are taking almost like a multi-step approach to kind of diffusing AI within the platform. So that's, you and I kind of look at it.
Yeah, I think that's important. And I think right now, we're at the initial stage, right? We want to show that these AI workflows have that ROI, are showing value. But I actually think this is foundational. It's kind of the stepping stone to where we're going to be in 10 years, in 15 years, because healthcare is going to look a lot different, right? And I think I heard this, and I hate quoting stats that I can't remember, but I heard this stat where, allied healthcare workers, there's going to be a reduction in allied healthcare workers, and we're actually going to have to be comfortable with AI maybe filling in those tasks, like maybe prescription renewals, and not take time from a clinician to do that, because we're going to have less of them. So I think the work we're doing now to cement AI within workflows and build trust against these AI workflows will serve us well as we get, 10 years down the road and have to utilize it a little bit more, use a little bit differently. So.
I agree. I completely agree. And in all the, the guardrails, the challenges that we have, I'm optimistic, Mike. I think AI as a technology in terms of what it's capable of when applied right, can be the greatest force of change that we've ever seen in healthcare. And that's what we are leading on, So leading to something that AI needs, and I think the whole sector needs, which is more, standardization, policy, regulations, the things that you and I are participating in with DEFCA as well. One of the things that I've been thinking about is you always want policy to be ahead of adoption, regardless of what it is, right? So you don't have a social media type of situation in healthcare, right? But if the gap between the policy and adoption keeps widening, you have the risk of just being an endless loop of policy making without creating real value. Are we at risk of that with everything that you're seeing? I know TEFCA adoption numbers are real. I mean, we see it. We are participating in it. That's real. But in general, do you see a risk of this gap between policy and adoption widening in the coming months and years?
So I think that policy, exchange purpose, the queue hinge structures, those things are real, right? But standards can only take us so far, and we need to make sure that workflows are aligned with some of these incentives. So I think policies get us, a certain way there. But unless we're actually looking at those policies, making sure they make sense relative to how operations work in the day-to-day, healthcare setting, to your point, then I think there's going to be this disconnect. But I think that if we can keep policies in line with reality, then that's kind of when we see true progress. There's that CMS aligned network initiative going on out there right now. And I think there's some of that, right? Where like CMS is bringing in the private sector to come in and help solve some of the problems. And I think that's their way of, bringing in boots on the ground that are actually living it day to day to make sure, see how these policies can keep aligned with realities. I think when we talk about interoperability, previous in the past, maybe it was more of a technical hurdle, but now to your point, it's a policy challenge, it's a technical challenge, it's a governance challenge. And I think all of these things need to coexist, and they need to be aligned. And to your point, if they're not, then you're going to kind of get this disparity between policy and reality. And this is when we don't actually see the real value to some of these efforts. And I definitely would not like to get back to a time, do not want to get back to a time where, we're coding product to meet a regulatory measure, but not actually meaningfully using it or actually realizing, its intent. So I think it's a great question. And I think we all have a responsibility to work through these work groups like we are with some of these TEFCA work groups to ensure that these policies are in line with the reality, and we all kind of work toward that common objective.
And one of the things I think about, Mike, is when we do these initiatives and we are all stakeholders in this, we are missing the most important stakeholder in the process, which is the patient.
Yes.
Right. So think about the scenario where we come up with the most, what we think is best fit policy, right? We are all aligned. We turn it on, and we apply it. The patient is a consumer of it, right? Yeah. But in today's world, the patient has the right and the freedom to take it and, let's say, for example, make a decision based on something that is fed to a ChatGPT, for example, right? Yeah. How does that decision made by the consumer kind of like loop back to the policy, for lack of better words? It's something that I think about, that it can be something that can become very dangerous and risky and harmful if there's no thought to that feedback loop from a patient perspective.
Well, I think that's a key point you're making here, is that, I think historically we always looked at the, policies, even the technology is about how a health system is sharing data to service the patient, right? But I think we need to take the health systems out of it a bit and actually put the patient at the center of their own data, right? Because it's not a health system's data, it's the patient's data, right? 100%. And the patient should consent to how it's being shared and how it's being used. And so if they're the main driver for interoperability, which I think we're kind of shifting in that direction, especially even with some of the purposes of use with TEFCA, individual access services, which is giving patients control. The use case that you just mentioned, which is a patient sharing their data with the AI to make sense of it, right? And so I think once patients become the drivers of their data, then those policies need to align with the patient and not necessarily the health system, who in this particular case is simply a steward.
I completely agree, Mike, and thank you for that. We work with a lot of organizations that are beginning to wake up to this, I need to have an interoperability backbone for us to be successful in these payer contracts, right? Yeah. Like these are IPNs, CINs, ACOs, and whatnot. What would be your advice to them, Mike, in terms of, we tell them what we see and we tell them what they need and we tell them why this is important, whatnot. But from your vantage point, what would your advice be to these provider organizations that are, thinking about, hey, how can I put together a strategy and an operational reality around interoperability so I can then be successful in value-based care, in this payer contract, or my patient satisfaction scores, right?
Yeah. So I think that interoperability isn't just like a technology problem. Interoperability is a strategy, right? And you need to know what problem you're trying to solve for. Are you reducing clinician burden? Are you trying to improve care transitions, supporting value-based care, or enabling AI, right? So when you have that clear purpose, the technology choices fall into place. And ultimately, you also have to account for just not, can I get access to the data, but what do you do with the data? Does it make sense within workflow, right? So if you're trying to reduce clinician burden, are you able to summarize large amounts of data in an intuitive way within workflow? If you're trying to support a value-based care use case, right? Do you have the mechanisms by which you're bringing in those risk scores and care gaps and making them make sense and allowing clinicians to close them to close those care gaps within workflow? So I think it's treating interoperability as a strategy and then actually looking at it as a data enabler, right? Because how healthcare is being driven by data, data insights as it relates to treating the patient or supporting the organization or supporting the care team. So looking at interoperability as a strategy, looking at data as the conduit for how you're going to solve the problem and understanding the problem you're trying to solve.
Got it. And one of the things that I share with my customers, Mike, is I tell them, like, you got to focus on outcomes, right? And when you do that, functionally interoperability is invisible, right?
Exactly.
Right. So what is visible is the outcomes of having an interoperable backbone, right? So my preaching strategy is to focus more on outcomes. And then when you get that buy-in, at least at some levels, and you say, okay, to get there, this is what we need.
Agreed.
So it's kind of like begin with that end in mind,
Yeah, I mean, and that's kind of foundational to like what we do here at MEDITECH, right? When we talk about expanse, we talk about the investment we make in the infrastructure that powers the intelligence of the platform. And that investment is in the technology enablers underneath. Is how are we using data, just not externally, but internally? And how are we sharing that data with large language models? And how are we, exposing data to APIs that power health apps that complement the workflow? So I think the holy grail is when we're no longer talking about interoperability, the data is just there.
Yeah, amazing. Hopefully we'll get there soon, and I look forward to working with you on that, Mike. Thank you so much for your time. But I can't let you go until I ask you a fun question.
Sure.
Okay.
Yeah.
They'll probably be easy for you. So in the scope of interoperability, what is the one thing that you would keep as is, one thing that you would completely retire or remove, and one thing that you would reimagine? How it's done today.
Yeah. I'm a fan of policy that forces data exchange, right?
Excellent.
And so I would definitely keep that.
Okay.
What I would do differently, and I think we're doing that now, as it relates to that data exchange, I would not use CCD as a construct because that's a bloated concept and no one likes to use it. Embrace the patient at the center of their care and the patient making the decision as to where their data goes, as opposed to health systems and big tech determining how things should work.
That is awesome. Excellent. Mike, thank you so much. As always, I learn every time I talk to you. Truly appreciate your time on this episode, and good luck. I look forward to working with you.
Well, thank you for having me. I appreciate it. I had a great time.
You too. Thanks. Bye. If you enjoyed this episode, make sure you subscribe to our channels. Episodes will be posted once a month with a variety of industry leaders, and you can follow us on LinkedIn, Twitter, and Facebook as a Garajan. Have a good one.